Thank you very much. I have no disclosures for this presentation. So I'd like to start this talk by telling you a story, and to understand the story you have to understand a little bit about the geography from where I come. This is the western part, southwestern part of the province of Ontario, where there's a couple of cities right across the rivers from the United States. So we have a small town, Sarnia, which is across the St. Clair River from Port Huron in Michigan, and then there's Windsor, Ontario, which is of course across the Detroit River from Detroit. You know, people live on either sides of the river, have the same diseases. When they get sick, they're treated more or less the same way. But there are a few important differences about the way people receive health care, and one of which, and I'm going to focus on this, is the regulatory body that evaluates new technologies. So we've heard a lot already about the Food and Drug Administration in the US, which is the regulatory agency that regulates health products. We don't have an FDA in Canada. We have a branch of Health Canada that essentially does the same thing using more or less the same process. The particular technology I wanted to start with is the one that's pictured here. It's an intragastric balloon. It's a device that's intended to cause weight loss by putting a saline-filled balloon in the stomach. This is placed endoscopically, so it doesn't require surgery or incisions. It stays in the stomach for 6 months, at which point it must be removed, and patients lose weight. It's not entirely clear why they do. Ultimately, they eat less, whether this occurs because of a sense of satiety or some degree of gastric outlet obstruction and vomiting, but regardless, people do lose weight. So intragastric balloons are not approved for use in the United States by the Food and Drug Administration. They are approved for clinical use in Canada, and as you can see here in 2006, one such device and subsequently other devices were approved for market use in Canada, and started to be used and taken up. And because of those close proximate relationships between some American cities and the Canadian cities across from Lake St. Clair in the southwestern part of Ontario, there was a lot of interest in getting business from the United States, because there was a lot of interest developing in intragastric balloons as a weight loss intervention. And there was a lot of medical tourism, primarily from Michigan State, into these cities in Canada to have these devices implanted. And it wasn't just Americans that were coming up, it was also a lot of Canadian residents were getting these devices as well. Cost $8,000, and over the course of 6 months, typically patients would experience a lot of weight loss. Well, how effective are intragastric balloons? So there is a fair literature on this. Most of it comes from Europe, where these devices were evaluated and are also marketed. And I'm not going to show you all the tables, but I did reproduce the conclusions, and this is from a Cochrane collaboration review published in 2009, which essentially shows that when you compare intragastric balloons with similar interventions without placement of the intragastric balloon, so you may need to know you have to have a specific diet when you have this balloon implanted, but if you can compare the balloon and the diet with just the diet physician supervised, there's really no benefit. Patient lose the same amount of weight over a 6-month period. Typically they regain weight, obviously, when the balloon is removed. So they really have no obvious advantage over non-interventional therapies. And in addition to that, the study found that there were a host of what they called minor complications associated with intragastric balloons that didn't exist at all with the comparators. And one thing I can tell you that I've never seen in any publications, but I've been involved in some reviews of the use of these technologies, that in some cases they're very dangerous, and there have been a number of deaths in Ontario, primarily, as it turns out, because of gastric perforation that have occurred when endoscopists have tried to remove these balloons. I can't tell you how many have been implanted because it's hard to track. These are done in the private system, but there's been at least 3 deaths that I know of that have occurred associated with the device. And it prompted me to think a lot about the use of these devices and to ask the questions, why is it, because this happens very commonly, that people tend to seek out new technologies when there's no real evidence of benefit, but there's just a huge attraction of the fact that it's new, that it's technology, that it's innovation, that it's perceived to be an advancement. Well, why is it? I was asked to talk about semantics and patients' perceptions. What is semantics? Semantics is the study of meaning, of words and symbols. It's a difficult concept to explain, so I'm going to use this clip to perhaps give you an example so you get a better understanding of the use of semantics.
What are we really talking about here? Huh? What's the essence of what we're talking about? I'll spell it out for you if I have to. Prostitution.
Kidding, Alex. What is this?
Prostitution. Hey, we can say it. We're big kids now, right? You know, a lot of times it'll help you to understand a word if you break it down. So let's do that now, shall we? Pros doesn't mean anything. Forget about that.
Okay, maybe not a great example, but that's the idea, that words have meanings. Some of you may recognize that from the classic 1982 film Night Shift with Michael Keaton, his breakout movie, and Henry Winkler, the Fonz, who you may have recognized in the background. So there is semantic importance to the terms that we use for new technologies, and that has implications for the popular social understanding of technology. And this is how patients and typical people feel about technology in general. This is how they think about it. So starting from the old types of television sets, big consoles, black and white, evolve over time. And people's experience of technology is this. They can see it, they can feel it, they experience the benefits for themselves, and there's no doubt in anyone's mind that they would like to have a flat screen TV or a plasma or something compared to an old console, black and white television. They have a very strong sensory experience, and they can tell the difference, and it's very clear to people. And because of that social understanding, the meaning of technology is overwhelmingly positive. And this is very prevalent, and it's important to keep in mind whenever we talk about technology. And these are some of the concepts that are connoted by terms that we use in technology. So they imply progress and innovation, improvement, increased reliability, and also these concepts of safety and effectiveness that we as physicians recognize are not necessarily associated by all departures from current practice, but that's not the perception that lay people typically have. So to what extent are patients influenced by language in decision making? And there's a bit of a literature on this, and I'm going to review it now, and then I'll tell you a little bit about a study we did a few years ago. And as you'll see, the answer is patients are influenced quite a bit by language. So this is a really interesting study that asked patients about their preference for how they would want to have a cholecystectomy, essentially to compare the conventional 4-port or multi-port cholecystectomy with single incision cholecystectomy. And if you just ask patients, which would you prefer, and you tell them one has 4 incisions, one has 1 incision, you show pictures of what the incision looks like, you get over 50% of people would want to have a single-port laparoscopic cholecystectomy. A few would want conventional treatment, and a lot had no preference. But this is before talking to patients about what was known in the literature about any complications and the novelty. But if you actually had that discussion and talked about what was an increased risk of certain complications, an increased risk of bile duct injury, all of a sudden you change preference quite a bit. So the percentage of patients who'd want a single port procedure goes down to 10% from over 50%. In a multi-port procedure, or the standard, all of a sudden 90% of people want the conventional therapy once you describe to them a little bit more about some of the trade-offs, some of the harms and the risks. Another really great study looked at approaches for acute appendicitis, specifically if patients would want to have a NOTES procedure, like a transgastric procedure for an appendectomy. Just by show of hands in a surgical audience, how many people here, if they had acute appendicitis, would want to have a NOTES appendectomy? Okay. So how many people here would want to have, just to make sure you're paying attention, a conventional laparoscopic appendectomy? Okay. So there were no hands that went up for a Notes appendectomy, but patients wouldn't mind. And if you ask them in surveys here, 30 to 40% of people would want to have a Notes appendectomy if you explain what's involved in the procedure. Some medical professionals, doctors, most of them non-surgeons, but also a lot of nurses, also make this implication that if it's technology, if it's an advancement, it's probably better. So the study we did had a similar focus. We looked at the influence of language on whether patients would want to have a robotic surgery to do a partial colectomy. And what we did is something called a discrete choice experiment, which was similar to the other studies, where you ask people, and these patients were just typical people, not necessarily people who had colon cancer, but whether they'd want to have a conventional laparoscopic or a robotic-assisted operation for a colon resection. And we described scenarios using two different frames or two different methods of explaining what a robotic colon resection is. One we called a marketing frame and one we called an evidence-based frame. So in the marketing frame, we described robotic-assisted surgery as state-of-the-art, innovative new technology. And in the evidence-based frame, we called it a promising new technology which has not been used extensively and with research regarding its safety and effectiveness ongoing. We described the scenarios entirely identically, and the subjects would do an exercise where they would choose their preference, robotic or laparoscopic, once with the robotic surgery described in the marketing frame and the other time with the evidence-based frame. And we would alternate the order just to make sure there wasn't a primacy effect. So what did we find? And you could probably predict what we found, but that in the marketing frame, so when we describe robotic surgery in a relatively positive way, just over half of the people would prefer a robotic-assisted procedure. And of course, when we described it using the other evidence-based frame, implying that there was some uncertainty about benefits and risks, only 24% preferred the robotic-assisted procedure. And there was a lot of people changed their minds. So of the 20 people who initially would prefer robotic-assisted surgery in a marketing frame, when you rephrase that and introduce some degree of uncertainty, most of those people changed their minds. So the language that we use and the words that we use are extremely important, and they do drive decision-making. I want to segue a little bit to go beyond that. So if patients are going to be drawn to the technologies, to what extent can we rely on published evidence to make our own good decisions about emerging technologies? And I'll show you it's not nearly as clear as we would like to think. So we've heard already a lot of discussion about the angel chick prosthesis, more I think than I've ever heard in one session in my entire surgical career. By way of disclosure, I've never seen an angel chick prosthesis. I've never inserted one or removed one. They left the surgical armamentarium before I even started my training. But whenever my teachers would talk about treatments for reflux and go through the list, the angel chick prosthesis was always mentioned, and they would always add the phrase, only in order to be condemned. So it was clearly, in my mind, a disastrous procedure. They would talk about removing these things that had eroded And I would think, well, so you'd probably see this in the literature somewhere if we Googled or, PubMed search on angel chick prosthesis. What's the literature now going to show me in 2014? And it doesn't show you very much. Certainly not much that's negative. There's a lot of still published, very dated articles showing benefits of this prosthesis, but the negative articles look kind of like this. So this was published by an Australian group in 1991 that says, we conclude that the angel chick prosthesis is an effective anti-reflux device, but interferes with esophageal function in some patients requiring removal. And we think the rate of removal of the prosthesis is too high for its routine use in the treatment of GERD. When I read something like that, it seems pretty mild compared to the way, I was taught about the risks of this device. And I'm going to just talk about one more device. This is enteric, so a more recent example. This was also a treatment for gastroesophageal reflux disease that was, the way it works was to inject a polymer into the muscular wall of the esophagogastric junction to act as a barrier against gastroesophageal reflux. So Enterix was approved by the FDA in 2003 for routine clinical use to be marketed and used in routine clinical care, which it was, until 2005, when it was withdrawn from the market. And this is the Dear Doctor letter, and very strong language, says physicians should stop injecting enterics immediately and follow the manufacturer's procedures for returning unused products, and lists a whole bunch of harms, including perforations, mediastinitis, pneumomediastinum, etc. And again, if you weren't following these, the FDA disseminations, and if you just wanted to do a literature review and figure out, well, how valuable, how dangerous is enterics, let's say you were doing a health technology assessment for a government, what would you find? So as of a couple of days ago, if you do a PubMed search using the term enterics, there's 22 publications. And none of them are along the lines of this device has been withdrawn from the market or has these serious harms. It's generally a fairly positive literature. So that leads me really to the two summary points I want to make, one of which is that because of the language that we use and the social understanding of new technology, that patients seek out new technologies, particularly when they're framed in a positive manner. And also, as providers, you can't rely on the published literature to give you good information on the safety and effectiveness of emerging technologies, because really there isn't a very good published literature on new technologies by and large. Thank you very much for your attention.